Hi guys, welcome back. Yesterday we have done some questions on endocrine and I've asked my team to give me another slot to cover another few important questions on endocrine. So today we will do REMAT as per the schedule. We will be covering two major questions and I will be giving notes on two minor questions as well, that is Sjogren's and Behçet syndrome. The other questions from REMAT are unlikely to come from medicine per se. The rheumatoid arthritis, mostly questions will be from orthopedics and that will be addressed in orthopedics. So let's start with the first and the most important topic from rheumatology, which is the SLE. Hi Ritik, hi Arpit. Okay. So SLE, mostly the questions will go like this. Discuss the clinical features, diagnosis and management. So first let me tell you, when you're writing about clinical features, your teachers are expecting you to mention under different organ headings, like, okay, what are the manifestations of SLE when lungs are involved, when heart is involved, when nervous system is involved, when blood is involved. And among them, they're also expecting you to mention the most common one, like what is the most common neurological manifestation, what is the most common hematological manifestation, what's the most common renal manifestation. So we are supposed to write that. Now when it comes to diagnosis, most importantly, they are not asking you to precisely write the classification criteria, because it's not easy for even a practicing clinician to remember the classification criteria for all rheumatological disorders. So at least in a prof exam, as long as you're able to elaborate the clinical features and the antibodies and laboratory investigation, it's fair enough. Just mention the name that we will be following the ACR EULAR classification criteria for classification of cases into SLE. And then when it comes to management, you should be able to write what is the preferred standard treatment, and when the standard treatment fails, what are the advanced treatment options available. If this is done, out of 10, 7 marks will be given to you. Okay, so let me begin by the basics. So when we are talking about SLE, of course, we have to begin with the epidemiology. And just like, in fact, the SLE is the prototype example for autoimmune disorders, because it follows so many basic rules that we see across various autoimmune disorders. Now, majority of autoimmune disorders are more common in females. And when we are writing about SLE also, we are writing the same. The SLE is more common in females than males. And we are all aware of this golden ratio of 9:1. So if there are 10 patients with SLE, 9 are females, 1 will be probably a male. And then, just like most other autoimmune disorders, SLE is also typically common in the middle-aged females. So it is common in second to fourth decade. You can write second to fourth decade, or you can also write it as reproductive age group. SLE is more common in the reproductive age group. Either you can mention it as middle-aged women, or second to fourth decade, or reproductive age group. Now in the Viva OSCE, sometimes teachers might ask you, when do you consider it as late onset? The typical SLE begins between second to fourth decade. When do you call it as late onset? So if the onset of SLE is after 50 years, then we call it as late onset SLE. Okay. Now what are the risk factors? So when it comes to SLE, I want you to mention 3 important risk factors. The first, and in fact the most important one that your teachers are particularly looking for, is the deficiency of complement factors C1q, C2 and C4. Then second one is TREX1 mutation, and the third one HLA association. In HLA association particularly, I want you to mention HLA-DR3. Okay. Now first let us address the complement part. So complement C1q deficiency is the strongest risk factor. Strongest risk factor. Okay. And then DR3 is associated with increased risk. On the other hand, I also want you to make a note that the HLA variant DR4 is associated with protection. So DR4 is protective against SLE, but at the same time, I want you to remember that DR4 protects you from SLE, but increases the risk of developing rheumatoid arthritis. DR3 increases the risk of SLE, but reduces the risk of rheumatoid arthritis. These are genetic factors. Then risk factors can also be considered under the heading of environmental factors. Females, of course, if you're talking about females at increased risk, female hormones will come into picture. Yes, the exposure to estrogen is associated with increased risk of developing SLE, especially when someone is given oral contraceptive pills. And then Epstein-Barr virus infection, I think I've told this earlier also in the Farre series, that if it is an autoimmune disorder and you don't know what to write as risk factors, close your eyes and write Epstein-Barr virus infection. Even if your teachers are not sure, they will not scratch too much of their head to verify whether Epstein-Barr virus infection is linked to this particular autoimmune disease or not. They will consider it as fairly acceptable. Tobacco in all forms, smoking consumed orally in all forms is associated with increased risk. Then silica. Now silica exposure, in fact the silicosis, increases the risk of developing SLE because silica is an immunoadjuvant. It makes the antigens more palatable to immune system, so body produces more stronger immune reaction. And then vitamin D deficiency. Again, vitamin D deficiency, you can close your eyes and write for various autoimmune disorders. I think we discussed about it when we were talking about multiple sclerosis as well. So these two remember and then make it as a blanket answer. You're talking about any autoimmune disorder, just write these two sentences there, and it is fair enough. Teachers will pass it off. Okay, now these are environmental risk factors. Now that we know the risk factors, let us see what all clinical manifestations we will develop in a patient with SLE. Just addressing some Viva OSCE points. SLE is primarily a disorder where our own body antigens or body proteins, tissue proteins, are perceived as antigens by immune system, and immune system produces antibodies against them. Now these antibodies bind with our own antigens to form what we call as immune complexes, and these immune complexes get deposited in the organs. Like if this is an antigen, you might have heard about anti-dsDNA antibody that we get. So double-stranded DNA is acting as an antigen. So let us think of this as a double-stranded DNA. Against it, body produces an antibody that will come and bind it and form a complex. So now what I have is a immune complex. These immune complexes start circulating and they get deposited in the organs. And in the organs, whichever organ these immune complexes are deposited, they become dysfunctional. They get affected. Now there will be an inflammatory attack on that particular organ where there is immune complex deposition, and the organ gets inflamed, becomes dysfunctional. That's how we are getting so many manifestations in SLE. So then you should only tell me what type of hypersensitivity reaction SLE can be considered as. Yes, it is type 3 hypersensitivity reaction. SLE is an autoimmune disorder where organ dysfunction is due to immune complex deposition, and that is why it is considered as type 3 hypersensitivity reaction. Okay, now once we are talking about autoimmune disorders, especially rheumatological disorders, you should also remember that there is organ inflammation, and if there is organ inflammation, there is some cytokine, inflammatory cytokine, is taking the main lead in causing the tissue damage or inflammation. Like imagine now, I developed SLE, body produces antibodies against my own body's proteins, so they formed immune complexes. Now these complexes, let us say they are deposited in kidney or the skin. Now once the immune complex got deposited, body will send an inflammatory response. So this response is spearheaded by one leader. That leader is the principal cytokine. Just like if there is a battalion of army, there is a commander in front of it. So who is that principal commander responsible for causing the tissue inflammation? So the principal cytokine involved in the pathogenesis of SLE is going to be interferon 1. Why am I stressing on this? Because going forward, when we are going to treat a patient of SLE, this becomes our target. If I block this, if you kill the commander of your enemy army has to surrender. So same here, we have to inhibit interferon 1. And for that matter, I want you to remember what are the principal cytokines in various rheumatological disorders. For example, now we'll studied about SLE, it is interferon 1. If you talk about rheumatoid arthritis, the principal cytokine is TNF alpha. That's why when Dr. Alekat teaches you about rheumatoid arthritis, he says we will be using anti-TNF alpha drugs for treatment of rheumatoid arthritis, because there the joint damage, all of that is done by this TNF alpha. It is charging. It is the lead cytokine that is causing inflammation. If I have to talk about scleroderma, then it is transforming growth factor beta. You should remember all these cytokines because treatment will be targeted against them. So that in MCQ based exam or in Viva OSCE, you won't be confused. If a teacher says, I would like to use infliximab for treatment of SLE, you can counter him saying that, sir, infliximab is anti-TNF alpha drug, and TNF alpha doesn't play a role in the pathogenesis of SLE, so it won't be of use. But yeah, sir, you can use that in a patient with rheumatoid arthritis. Okay. Ahmad, I will address your query. Okay. So SLE, what introduction you have to write? It's an autoimmune disorder, primarily a type 3 hypersensitivity reaction. It is more common in middle age or reproductive age group females with a female to male ratio of 9:1. And among the risk factors, main genetic risk factors are complement deficiency, particularly C1q, C2 or C4 deficiency, TREX1 mutation, and HLA-DR3. Environmental factors include exposure to estrogen, Epstein-Barr virus infection, tobacco in all forms, smoking. Remember, a small quantity alcohol intake may be protective for SLE, but just because I said that don't start drinking alcohol, it brings a lot more troubles. Silica exposure and vitamin D deficiency are risk factors. The main cytokine involved in the pathogenesis of SLE is interferon 1, which is responsible for the organ damage. Okay. Now, why interferon 1 started targeting the organs? Because there were a deposition of immune complexes. And what are these complexes formed of? Our own tissues antigens and our own antibodies produced against these antigens. So that's why we should also have a fair idea about which antigen is responsible for inciting which antibody and which organ is mainly going to be targeted by these particular immune complexes, right? So that's why I will address it from the perspective of Vygotsky as well as MCQ. Antibodies that we are going to get in SLE and their clinical correlations, so that you can write it for your prof exam and also answer the Vygotsky. So among a list of antibodies that we see in a patient with SLE, the most sensitive, the most commonly encountered antibody, the most sensitive by default also means most common as well, and that is ANA, anti-nuclear antibody, or ANA. Now ANA, in fact, when I got my routine blood test done a couple of months back, my ANA was reported as positive. Now, does that mean I have an autoimmune disorder or I have SLE? The answer is no. Why? Well, ANA, when done by different methods, you get different titers. So all the ANA estimated by all methods is not equivalent. That's why we need to do ANA with the ideal method. So what is the recommended method? The recommended method is indirect immunofluorescence. Indirect immunofluorescence. So when you do ANA with indirect immunofluorescence, then only it is reliable. And even when it is done with indirect immunofluorescence, usually abbreviated as IIF, indirect immunofluorescence, 1:40 titer may be positive in 5% of the population who do not have any of the autoimmune or rheumatological disorders. So to call it as significantly positive, you need to have a titer of more than or equal to 1:80. Anything less than that is not considered significant. 5% of the population may turn positive if you hold a lower titer. But ANA, though most sensitive, it will be seen in majority of the SLE patients. It is not specific. As I've already told you, it is positive in common individuals also. So just because someone got ANA positivity, it does not mean he has SLE. So then if I want to do a test which confirms that he is indeed a case of SLE, what test it could be? It should be highly specific. And the most specific antibody test that we can do in these patients is going to be anti-Smith. Anti-Smith antibody is the most specific antibody. But it is lacking the sensitivity. Means a negative anti-Smith antibody does not rule out the SLE. A positive ANA does not indicate that it is SLE. Similarly, a negative anti-Smith does not rule out. If it is positive, you know that this person has SLE, but negativity does not rule out because it's not highly sensitive. So what is the best investigation that I should be doing whenever I'm having a case of SLE? ANA is the initial screening test, being the most common. But once that comes positive, it's not equal to SLE. It could still be a chance occurrence. So in that case, I have to go for a relatively specific, but anti-Smith is not a good choice because it lacks the sensitivity. But I have a test which is reasonably sensitive, reasonably specific. The second most common, the second most sensitive, and the second most specific. And that is going to be anti-double-stranded DNA antibody. And particularly this anti-dsDNA antibody, this has some more relevance. What is that? This not only highly specific, but it is also correlating with the disease activity. It correlates with disease activity. Now, what do I mean by that? Means ANA titers. See, if I am suspecting SLE, I will do ANA as the initial screening test. If it comes positive, probably in this patient's lifetime, never again I will do ANA, because ANA titers do not correlate with disease severity or activity. So let us say now it is 1:160. Okay. According to the standard prescription method, it is positive. Now I declare it as positive. 6 months later, the patient comes back for follow-up. And let us say I did the ANA titer again. And now it is further worsened. It is 1:320. Okay. So in that case, should I say the disease is worsening? The answer is no. Because the ANA titers and disease severity do not correlate with each other. But on the other hand, anti-dsDNA titers correlate. So let us say I had 1:120 initial titer. And then when patient came back for follow-up, it has become 1:320. That means the disease is flaring up. It is indicating how active the disease is. Higher the titer, more active the disease is. And it not only correlates with disease activity, it also correlates with the risk of lupus nephritis. So the more the anti-dsDNA titer, the chances of SLE affecting the kidney is high. Lower the titer, chances of SLE affecting the kidney is less. Okay. Now, drugs are also known to cause SLE, and in patients who have drug-induced SLE, they have an antibody. What is that antibody? It is Anti-Histone antibody. And particular about the drug-induced SLE is that it is reversible. You stop the drug, slowly the Anti-Histone antibodies disappear, and SLE manifestations that patient has, the Malar rash, photosensitivity, even organ involvement, all of that improves. But the SLE that was spontaneous onset, not caused by drugs, that is not reversible. Okay. So in the Viva OSCE, your teachers might ask, what are the drugs known to cause SLE? In your pharmac book, you get a long list of drugs known to cause SLE, but I'm just listing few important ones. The important ones are isoniazid, hydralazine, methyl dopa, minocycline, quinine, and procainamide. Just remember at least 2 or 3 so that you can open the mouth, and once they hear 1 or 2 names, they will move forward with the next question. Okay. So far what you have studied about antibodies? Physician, Antash, yeah, we are continuing. See, Ahmaduka, because there are slot crunch or a time crunch, and there are a lot of students with exams quite nearby, we probably could not space out so many sessions. But in the MedEd app, there is a Farre section. In the Farre section, you have the Farre notes. So all the important questions, even the ones that we are not able to address on the YouTube session, are covered. So what I'm trying to do is, on the YouTube, I'm trying to prioritize the most important ones, and those topics which often teachers are going to ask in your bedside discussion or Viva OSCE table or instrument table also, so that these are addressed. The remaining simple questions which you can just read and write are already there in the Farre notes. So in addition to the YouTube, just use that as a complementary stuff, and you should be able to cover everything that is likely to be asked in your prof exams. Okay. Now, in terms of antibodies, the most sensitive is ANA. You should know that. The most specific is anti-Smith. Second most sensitive and second most specific is anti-dsDNA, the most important antibody in SLE. Apart from that, in drug-induced, you have anti-Histone. Okay. Other than that, we have some more antibodies, like you have anti-SSA, anti-SSB, which are also called as anti-Rho and anti-La antibodies. Then you also have anti-ribosomal P antibodies, anti-neuronal antibodies, and anti-U1 RNP antibodies. So they may ask you their correlations as well, right? So first, let me start with this anti-Rho or anti-SSA antibodies. These anti-Rho or anti-SSA antibodies correlate with the increased risk of SLE patient developing Sjogren's syndrome. So SLE plus Sjogren's syndrome, it correlates with that if already patient has SLE. In addition to that, it also correlates with the skin manifestation of SLE. Apart from Malar rash, there are other manifestations like discoid lupus erythematosus and subacute cutaneous lupus erythematosus. So if you have SLE plus this anti-Rho antibody, the chances of you developing this subacute cutaneous lupus erythematosus risk is high. And the most important thing here is that this anti-Rho antibody correlates with the risk of developing neonatal lupus, a very, very important MCQ point. What does that mean? Let us say, because we know that SLE is more common in the reproductive age group. So let us say a 22, 23-year-old female has SLE, she becomes pregnant, and when we get her antibody profile done, I find this antibody, anti-Rho antibody in her is positive. ANA should be positive, anti-dsDNA will also be positive, and anti-Rho is also positive. Now, the interpretation for me is that if she has these anti-Rho antibodies, these antibodies will have a transplacental transfer to the fetus. And in the fetus, it can cause neonatal lupus. And in the fetus, particularly, these antibodies affect the heart. And it can cause heart blocks. The neonate may be born with or will develop heart block in the immediate post-birth period. The neonatal lupus is a transient illness. If heart blocks don't develop, it is kind of self-limiting. But heart block can be life-threatening. So that's why we should be very cautious in monitoring this mother and the fetus and also treating her SLE. Okay, so this is a very, very important MCQ point that I want you to remember. And then anti-La or SSB, which also correlates with Sjogren's. The only difference between anti-Rho and anti-La is anti-Rho, in addition to Sjogren's risk, it is also associated with risk of neonatal lupus. SSB does not correlate with the risk of neonatal lupus. So let us say I have a pregnant woman with anti-Rho negative, but anti-La is positive. So she may develop the Sjogren's syndrome with the dryness of the eyes and all that, but she will not likely transfer these antibodies to the growing fetus, and the chances of neonatal lupus is low. Then we have anti-ribosomal P antibodies, which is associated with increased risk of depression and psychosis in SLE patient, and anti-neuronal antibodies, which are associated with the risk of CNS lupus. And then the next antibody that I'm listing here is particularly important. Anti-U1-RNP antibodies. Repeatedly asked MCQ antibody, in fact. It correlates with the risk of something called as overlap syndrome or mixed connective tissue disorder. Now, what do I mean by mixed connective tissue disorder? Mixed connective tissue disorders. So first, let us understand what do I mean by overlap syndrome. Overlap syndrome refers to collection of multiple rheumatological disorders in a single individual, like two or more than two rheumatological disorders in the same individual. Means, like, let us say I have SLE and I also have rheumatoid arthritis. So more than or equal to two rheumatological disorder in same individual is overlap syndrome. So for example, I told you SLE plus rheumatoid arthritis. In fact, there's a name coined for it. It's called as rupus. Rheumatoid plus lupus combined. It's called as rupus. Rupus is an overlap syndrome. Example, SLE plus RA. So that's an overlap syndrome. But an overlap syndrome where you have two or more than two rheumatological disorders, and in that patient, if you find this antibody positive, anti-U1P RNP antibody positive, we will call it as mixed connective tissue disorder. So please have this conceptual clarity. Overlap syndrome means two or more than two rheumatological disorders in one individual, and mixed connective tissue disorder means we have an overlap syndrome where, like, we're talking about SLE right now. So let us say patient has SLE. In addition to that, he also has Scleroderma, means two rheumatological disorders in the same individual. So now I can call this as overlap syndrome. But this overlap syndrome, patient, when tested for this particular antibody, that is anti-U1-RNP antibody, then it becomes a case of mixed connective tissue disorder. So if I had other antibodies, like I had SLE plus Scleroderma, I had ANA, I had Anti-Centromere antibodies, but U1-RNP antibody is negative, then it is just an overlap syndrome. But if this antibody comes into picture, then we will call it as mixed connective tissue disorder. So this antibody is the hallmark or a diagnostic clue for mixed connective tissue disorder. Okay, so these are important antibody correlations that you need to remember. Now let us talk about the clinical manifestations. So we already have seen a lot of antibodies, and they are going to form immune complexes by binding to their target antigens, and those complexes are going to get deposited in the organs, and those organs are going to get affected. So what all clinical manifestations we are going to get? So the first thing is, there is a new term that we are talking about in SLE from last 15 years, that is constitutional symptoms. So in the past, SLE is always about the involvement of skin, musculoskeletal system, and internal organs. But apart from that, general symptoms are very common. So we call those general symptoms, not specific to an organ, as constitutional symptom. And the most common constitutional symptom these patients develop is fever. In fact, we had 1 or 2 cases of SLE diagnosed as a team of infectious diseases, medicine, rheumatologist, all put together, when we had pyrexia of unknown origin cases where patients were presenting with recurrent fevers, and we were not getting any other specific organ manifestations to start with. But as the time progressed, we were still investigating, they started showing up the other organ involvement, and then things became clear. Antibody profile suggested a classical SLE, and we were able to diagnose it as SLE. So sometimes they can present as fever, and if fever is the only symptom to present with initially, and you don't have any other organ involvement, you will be like literally lost finding the cause. So fever is a constitutional symptom. That's the most common constitutional symptom. Apart from that, they can have generalized fatigue, malaise, and all, and you can write that. When it comes to skin, the most common dermatological manifestation is going to be what we all know, that it is malar rash, which is also called as butterfly rash. Butterfly rash. Few points about this rash. We should know that this rash that we see here characteristically spares nasolabial fold. Spares nasolabial fold, and it is photosensitive. What do I mean by that? So I gave you an example of a female with fever. We were struggling to find out the cause. 3 or 4 OPD visits, and then even inpatient evaluation of 3-4 days. Me, my colleagues, the infectious diseases team, or even the other specialties where we had referred, none of them spotted the malar rash. The simple reason is this rash is photosensitive. So when this lady was exposed to sun, she was developing the rash, but when she was indoors, not getting exposed to sun, the rash fades away. So it need not always be present, right? It is a rash which flares up on exposure to sun, can subside when there is no sun exposure. It is a highly photosensitive rash. Okay. Apart from that, you have other rashes like subacute cutaneous lupus erythematosus and discoid lupus erythematosus. Right now in the prof exam answer sheet, it's not required. As long as you're able to talk about the butterfly rash, your teachers will be more than pleased. Then musculoskeletal system also gets inflamed because of the immune complex deposition, and in the musculoskeletal system it causes polyarthralgia or polyarthritis. What is the difference between arthralgia and arthritis? Arthralgia, patient is merely complaining of pain. Arthritis, there is evidence of joint inflammation. What is the evidence of joint inflammation? Tenderness, redness, and swelling. If there is no tenderness, no redness and swelling, the patient is just complaining of joint pain, it is arthralgia. But on examination, if you notice the joint is tender, red, or even warm and swollen, then you know it is inflamed. Okay. Now this polyarthritis, tell me how similar it is to rheumatoid arthritis and how dissimilar it is to rheumatoid arthritis. Because rheumatoid arthritis is also a condition where you get polyarthritis. Yes, this polyarthritis typically affects small joints more than large joints. Affects small joints more than large joints. Rheumatoid arthritis is also same. Rheumatoid arthritis is also affecting small joints more than large joints. So in terms of limb involvement, this affects upper limb more than lower limb. So in other words, I can say that the SLE arthritis targets the upper limb small joints more than lower limb small joints. Rheumatoid arthritis is also same. Then what is the difference? Rheumatoid arthritis spares DIP, distal interphalangeal joints. Most often SLE also spares them. Then what is the difference? The SLE arthritis is non-deforming arthritis. On the other hand, rheumatoid arthritis is deforming arthritis. So it causes joint deformities, not just the joint inflammation, it causes joint destruction, and because of that, joints become deformed. In SLE, you don't get all those deformities, swan neck, right? The Z deformity, all those deformities are not encountered in SLE. But this arthritis is non-erosive, and thus being non-erosive, it does not cause deformities, true deformities. It can cause pseudo deformities, but true deformities do not occur in a patient with SLE, right? I hope you understood that point. But it can cause pseudo deformities. What do I mean by pseudo deformities? Joint surface is not damaged. Joint surface is fine, but the surrounding soft tissues, because of the inflammation, they can become lax. And that laxity of the surrounding soft tissues can make the joint appear deformed. But it is reducible. So like if I have this swan neck deformity in rheumatoid arthritis, can I reduce it back to normal? No. It's permanent, disfigured. But SLE, sometimes you have these deformed appearances because of the weakness of surrounding soft tissues. The tendons, ligaments and all are weak, but you can reduce it back. And such deformity is called as Jacquard's arthropathy. The picture that you see here is, it looks like the swan neck deformity of rheumatoid arthritis. But then when this patient's joint deformities we try to reduce, it could be reduced. And when we are able to reduce it, we call it as Jacquard's arthropathy. Called as Jacquard's arthropathy. It's a pseudo deformity that can be reduced. They are due to laxity of soft tissues. In these patients, there is no true erosion of the joint surfaces. In rheumatoid arthritis, there is erosion of joint surfaces and there is pannus formation. You don't get it here. Faizan, absolutely right. These are non-erosive. Okay. So in terms of constitutional symptoms, the most common is fever. In terms of skin manifestations, butterfly or malar rash with photosensitivity is the most common manifestation. In terms of musculoskeletal involvement, the most common manifestation is the polyarthralgia, maybe eventually polyarthritis. And when arthritis happens, it affects small joints of the upper limb more than the small joints of the lower limb. Large joints are relatively less commonly affected, just like rheumatoid arthritis. The only difference being RA is a erosive arthritis which causes true joint deformities. SLE is a non-erosive arthritis. It does not cause true joint deformities. If at all you encounter a joint deformity in a patient with SLE, it is a pseudo deformity, what we call as Jacquard's arthropathy. It is because of laxity of soft tissues. You can easily reduce it back. Okay. Now coming to the other organ involvement, it also affects the central nervous system. So what CNS manifestations we can expect in SLE patients? The most common CNS manifestation in a SLE patient is going to be cognitive dysfunction. What do I mean by cognitive dysfunction? Cognitive dysfunction refers to decline in higher mental functions. So when we think about nervous system, we can say that it has three broad category of functions. First one is motor function, movement of all muscles so that we can move body parts to do motor functions. Second is sensory, right? Get all the sensory information from the body parts and process and understand what is the sensation that we are feeling. The third is higher mental functions, thinking, emotions, memory, thought process, abstract reasoning. All of these are our higher mental functions. So when higher mental functions get impaired, we will call it as cognitive dysfunction. So SLE is not just a simple disease that your skin, joints and other organs get affected. It affects the brain and it can reduce the ability to execute higher mental functions. Okay, so I'm just asking one simple question. What is the difference between cognitive dysfunction and dementia? What is the difference between cognitive dysfunction and dementia. Can anybody tell me what is the difference between cognitive dysfunction and dementia? So decreased higher mental functions is equal to cognitive dysfunction. And if the cognitive dysfunction is severe enough, making an individual become dependent on a second person or a third party to carry out his day-to-day activities of living, then we call it as dementia. So if there is cognitive dysfunction, and in addition to that, I have dependence on others for activities of daily living, then we call it as dementia. What do I mean by that? Okay, let us say I have my higher mental functions, the thought process, memory is so severely impaired that I even forget to take bath, I forget to brush, I forget to eat my food. Now my family members have to tell me that, okay, it's time for you to brush, it's time for you to eat food. Then I have dementia. But if I have cognitive decline, but still I'm able to carry out my activities by myself, then we don't call it as dementia. We will call it as just cognitive dysfunction. Yes, SLE starts with this mild cognitive illness, but if the condition advances, it can lead to dementia. So SLE can be one of the causes for dementia. Okay. Now, apart from that, either you can discuss this in a separate heading called as psychiatric manifestations, or you can just write it under the CNS itself. It also causes depression, and even patients of SLE may develop psychotic illnesses. Having anti-neuronal antibody increases the risk of cognitive dysfunction, and anti-ribosomal P antibodies increase the risk of developing this depression and psychotic illnesses. Okay. Then when it comes to the respiratory system, now I want you to remember particularly when we're talking about the respiratory system. In the respiratory system, the most common, like if you talk about this, the cardiac system and respiratory system, the most common manifestation of SLE, rheumatoid arthritis, and so many other rheumatological disorders is going to be same. That is inflammation of the coverings. What is the covering of heart? Pericardium. What is the covering of lung? Pleura. Because all these inflammatory cytokines that are being formed, like interferon 1 in case of SLE, TNF alpha in case of rheumatoid arthritis, through the blood circulation, they reach the pleurae, they reach the peritoneum, they reach the pericardium, and they cause inflammation there. So the most common RS manifestation of SLE is going to be pleuritis. Pleuritis. This may be with pleural effusion or without pleural effusion. Okay. Apart from that, the SLE is also known to cause interstitial lung disease, ILD. And then third, a very peculiar condition encountered in SLE, not well understood. The mechanism is not well known, but the condition is well known. It is called as shrinking lung syndrome. Shrinking lung syndrome. This could be a 3-mark question in some of the university papers, asking you what is this so-called shrinking lung syndrome. So shrinking lung syndrome refers to a condition where an SLE patient starts developing some dyspnea, and when you do a PFT, you notice that the PFT is suggestive of a restrictive pattern. What is the restrictive pattern? FEV1 by FVC ratio is more than or equal to 0.7, but the total lung capacity and the forced vital capacity is reduced. Now, this restrictive lung disease, in a restrictive lung picture in a patient with SLE, should make you think of ILD. So you get an X-ray or a HRCT done, and the HRCT shows that the lung parenchyma is now, there is no ILD. You were expecting ILD based on the PFT, but there is no ILD. Then why this lung volumes are reduced? Why is it shrunken? The explanations are myriad, but not one explanation cannot explain exactly why this happens. One of the theories is that the lung is not getting fibrosed, so that's why you don't have ILD, but the surrounding structures, the pleurae, intercostal muscles, the fascia behind the intercostal muscles, they are getting fibrosed, causing the lung to shrink. The lung per se does not have a problem, the surroundings are making it shrink. That's the one explanation. Now, how do I recognize it? The shrinking lung syndrome presents with dyspnea. When evaluated, PFT will show restrictive pattern. So, and whenever we think of restrictive pattern, especially in a patient with SLE, we think of ILD. But when you do HRCT or chest X-ray, it characteristically shows two findings. The first finding is normal lung parenchyma, means nothing wrong with the lungs. But still you can see that the lung volume is reduced, and because of this reduced lung volume, there will be increased or elevated hemidiaphragm. Whichever side you have the shrinking lung syndrome, that side the diaphragm will be elevated because the lung volume is reduced, diaphragm appears higher. That you can see in this X-ray. You can see that the right hemidiaphragm is significantly more elevated. Of course, right hemidiaphragm is slightly higher than the left, but here it is significantly more elevated. So whenever I get an SLE with the normal lung parenchyma but elevated diaphragm, it should make me think of this condition called as shrinking lung syndrome. The lungs are shrinking, but there is no problem inside the lungs. So probably the surrounding structures are getting fibrosed due to inflammation. So these are the three respiratory system complications that we get in SLE. Now talking about the other organs. What other organs get affected? Yes, the cardiovascular system. So when CVS gets affected by SLE, the most common manifestation is going to be pericarditis. Pericarditis is the most common SLE manifestation of cardiovascular involvement. But again, I want you to know that just like acute rheumatic fever, the SLE can cause pancarditis. What do I mean by that? It can affect all the three layers of the heart. Pericardial involvement is most common, but it can also cause myocarditis. It can also cause myocarditis. What else it can cause? It can also affect the endocardium. And when the endocarditis occurs, is it because of bacterial infection? No. The inflammation of the endocardium is because of this interferon 1 and other inflammatory cytokines, not because of an infection. If it is because of infection, you call it as infective endocarditis. Here, if at all I do blood culture, it will come repeatedly negative. So then it is a aseptic endocarditis or sterile endocarditis. And when encountered in an SLE patient, there is a peculiar name given to it. What is it? It is called as Libman-Sacks. There is no pseudo-arthritis per se. There is pseudo-deformity. Pseudo-deformity is where it appears like there is a deformity. It's a pseudo-deformity. You can see if the same picture I give you and tell that this is a patient of rheumatoid arthritis, then you will say this is the swan neck deformity that you're seeing. Okay, but this deformity in a patient with SLE is not a true deformity because these joints are not damaged. The surrounding soft tissues have become weakened because of chronic inflammation, and because of that weakness, the joints are taking that shape. But if I pull it back, I can reduce the joints in their position, native normal position. So these are reducible deformities. That's why we call them as pseudo deformities. If I had a rheumatoid arthritis patient, if I try to realign their deformities, I will not be able to do. I will only be able to do that by causing more dislocations or fracture to the bones. Libman-Sacks endocarditis. So when endocardial involvement occurs in a SLE patient, we call it as Libman-Sacks endocarditis. And there is also renal involvement in a patient with SLE, and when kidneys get affected, we call it as lupus nephritis. Lupus nephritis. Lupus nephritis is the second most common cause for death in patients with SLE. Once upon a time, lupus nephritis was the most common cause for death in SLE, but today it's no longer because we have more potent drugs to treat. Even if lupus nephritis happens, we're able to salvage a lot of patients by potent immunosuppressants as well as renal replacement therapy or dialysis or transplantation. So it is no longer the most common cause. Most common cause for death in patients with SLE is going to be coronary artery disease, which as such is the most common cause of death world over. And in SLE patients, the chance of developing coronary artery disease is high because they already have inflammatory burden. So that inflammatory cytokines can cause endothelial injury, trigger the clot formation, and you can have an MI. Okay. Now hematological manifestations. The most common hematological manifestation is anemia of chronic disease, because SLE is a chronic disease. And this anemia of chronic disease, so Tapa, we will address the rheumatoid arthritis in detail in a separate session, because we will get into a too detailed discussion if you go into rheumatoid arthritis, and the time constraint won't let me go to the other questions otherwise. So anemia of chronic disease is what type of anemia? Is it microcytic hypochromic, normocytic normochromic, macrocytic hypochromic? Anemia of chronic disease typically is supposed to be normocytic normochromic anemia. Normochromic anemia. So these are all organ manifestations. So to start with, skin, malar rash, constitutional, fever, musculoskeletal, polyarthralgia, polyarthritis, non-erosive type of arthritis, kidney, renal, lupus nephritis. Then in patients with the cardiac involvement, pericarditis is most common, but it can also cause myocarditis and endocarditis. Endocarditis is called as Libman-Sacks. Lung involvement, it manifests in the form of pleuritis, but it can also cause the ILD and shrinking lung syndrome, a peculiar complication of SLE. Okay. Now, I've already told you the most common cause for death in SLE is going to be coronary artery disease. Coronary artery disease. And the second most common cause is lupus nephritis. Lupus nephritis. So when someone presented to me with any of these cluster of symptoms like fever, polyarthritis, photosensitive malar rash, I'm already suspecting SLE, especially if it is a middle-aged female. Now for diagnosis, I don't have to rely on the classification criteria. I can diagnose based on the clinical grounds and the supportive laboratory evidence, like ANA titer positivity, Anti-dsDNA titer positivity, or any of the antibodies that we discussed. But if I want to list a patient of any rheumatological disorder for a clinical trial, like, okay, I have this patient of SLE and I want this patient to be part of a clinical trial for a particular drug. In that case, I can only list this case in that clinical trial if they meet the so-called classification criteria. The main objective of this classification criteria is to recruit cases for clinical trial so that all the patients recruited into the clinical trial are diagnosed on the same standard. So what I'm trying to say is that the classification criteria is not binding upon a doctor to use for a diagnosis. It's only for listing the patients for clinical trials. You can make a diagnosis based on the clinical context and basic laboratory evidence. You don't have to abide by this, but you should have a fair idea what this classification criteria is all about. So the classification criteria says that you can classify a case or list a SLE case to be considered as SLE for a clinical trial if they meet entry criteria and the score. What is the entry criteria? You should have a ANA positive with a titer of more than or equal to 1:80. I've already told you what is the preferred method. Preferred method is indirect immunofluorescence. Without ANA positivity, the case will not be listed in the clinical trials. But if I, as a doctor, can I diagnose it and treat as SLE? Yes, why not? Let us say I have a drug-induced SLE. I may not have ANA positive in those cases. I will have only anti-histone antibody positive. This case is not supposed to be considered for listing in clinical trials. This will fail the classification criteria. But still, as a doctor, I can diagnose it as SLE and treat accordingly, right? And after that, from the scoring, we will require more than or equal to 10 with at least 1 point from clinical criteria. So if you open the Google and find out this so-called ACR EULAR classification criteria, they will have two categories, clinical and laboratory. In the laboratory, they have mentioned about the anti-dsDNA titer and ESR, CRP and other stuff, biochemical test. And in the clinical criteria, all these manifestations that we discussed, skin, musculoskeletal, constitutional, fever, these are listed, and there are points or score given for these clinical manifestations. And I need at least 10 points from this to classify the case as SLE. And out of that 10, at least one should come from clinical. If all the 10 score comes from the laboratory test, like antibody panel, that won't be considered as SLE. Simple. Again, SLE is a clinical diagnosis. It's not a lab diagnosis. So if I have ANA, if I have anti-dsDNA and so many other biochemical abnormalities, I may get a score of 10, but if I don't have any of these symptoms, then I don't have SLE. So it's always about diagnosing and treating an individual and not the report sheet. Okay, so according to this criteria, let us say we have classified, or even if the criteria does not meet, I am strongly inclined to believe this is an SLE because classical epidemiology, middle-aged female, classical photosensitive Malar rash, ANA positive, anti-dsDNA positive, enough for me to diagnose it as SLE. Now that I've diagnosed it as SLE, how do I manage? Right, now let me tell you the principal cytokine involved is interferon 1, so I can target that. But should I go ahead with more advanced drug for all cases? No. Most SLE cases will require simple treatment. Like if Dr. Aleke has covered rheumatoid arthritis, then she might have told you that rheumatoid arthritis, the drug of choice for most patients is going to be methotrexate. It can be considered as a blanket treatment. Means if there is no contraindication, that is a drug that every rheumatoid arthritis patient will receive. If there are contraindications, we don't give, but if there are no contraindication, that is a drug that every rheumatoid arthritis patient will receive. After methotrexate, if they don't respond, then you keep on escalating the medications. Eventually, you go to TNF alpha blocking agents. Similarly, the blanket treatment for all SLE patient, or in other words, the drug of choice for SLE patient is going to be hydroxychloroquine. Hydroxychloroquine. But particularly, this hydroxychloroquine has certain side effects that we should be aware before we start. What are the side effects? First, it is associated with retinal toxicity, and if patient already has some retinal disease like diabetic retinopathy or nephropathy, and you add this drug, the chances of further worsening the retinal condition is high, the vision loss is high. So in that case, you should avoid it. It is contraindicated. It has retinal toxicity. So Sudhapa is absolutely right. The second one, hydroxychloroquine, prolongs QT interval, and because it prolongs QT interval, there is a chance that it may increase the risk of developing a polymorphic VT, a ventricular tachycardia. That particular type of polymorphic VT that happens in patients with prolonged QT interval is called as, it's a very, very interesting ECG image that you get, where you get this wave-like polymorphic VT. It looks like the waveforms that we used to sketch in the physics classes. What do we call this type of polymorphic VT? Risk of a type of polymorphic VT called as Torsades de Pointes or Torsades de Pointes. Okay, so before you give hydroxychloroquine for any patient, make sure their retina is screened by an ophthalmologist and you get a bare minimum ECG done, calculate the corrected QT interval, and if it is normal, retina is clear, then start hydroxychloroquine. Okay, so I'm just putting an image. You don't have to copy this in your exam, just for your understanding, which is the current guideline for management of SLE from the American College of Rheumatology. So for mild cases of SLE, our first line, second line treatment is all going to be hydroxychloroquine. So for mild case of SLE, hydroxychloroquine by default will be given. Okay, then even for moderate or severe cases, hydroxychloroquine will be given. That's why I called it as blanket treatment. It is for all patients unless contraindicated. But if hydroxychloroquine alone fails to control, then we bring the next class of drugs. What are the next class of drugs? We can start with the glucocorticoids. GC here stands for glucocorticoids. Or alternatively, you can think of immunosuppressants. If given a choice, I would like to keep glucocorticoids low or avoid and instead give immunosuppressants. Why? Because long-term use of steroids is associated with osteoporosis, peptic ulcers, infection risk, Cushing's syndrome, all of that. So I would like to avoid, instead use immunosuppressants like methotrexate, azathioprine. But if these drugs also fail or the condition becomes more worse, in that case, I might have to think of more advanced drugs. So what are the advanced drugs that you need to remember? So newer drugs include one called as belimumab. Again, simple, remember just this thing. We start with hydroxychloroquine, not well controlled. We add either steroids or immunosuppressants or both. If still not well controlled, then we go to the newer drugs. And the newer drugs are two. One of them is belimumab. which is a inhibitor of B lymphocyte stimulant. Inhibitor of B-LYS. B-LYS stands for B lymphocyte stimulant. Remember, the antibodies that are forming the immune complexes like anti-dsDNA, anti-Smith, anti-Histone, anti-ribosomal P, they're all produced by B lymphocytes or the plasma cells. So if I inhibit their proliferation itself, then the B lymphocyte numbers will come down, B lymphocyte activity will come down, the antibody production will come down. If less antibodies, less immune complexes means less organ damage, less inflammation. So that's why we can use this belimumab or B lymphocyte inhibitor. It's a monoclonal antibody, or you can write it as anti-B-LYS monoclonal antibody. Okay, and among the list, the latest one is anifrolumab, which is a monoclonal antibody against, remember what is the principal cytokine? The main cytokine responsible for the organ damage was interferon 1, and now we have drugs that can block it. So it's a monoclonal antibody against interferon 1. And if you look at the name, it is there in the name. It is a anti-interferon 1 monoclonal antibody. It's an anti-interferon 1 monoclonal antibody. So those can be considered if patients are not responding to your initial hydroxychloroquine and steroids or immunosuppressants. Okay, so that completes our management of SLE. Now SLE has a complication called as Antiphospholipid syndrome. Antiphospholipid syndrome is a current terminology. In the past, we used to call it as Antiphospholipid Antibody Syndrome. Many universities are fond of asking SLE plus APLA as a combined question. They will say like, list the important clinical manifestations of SLE and discuss in detail about APS or APLA. And this APS or APLA also filters into your OBG questions many times. Okay, so what is this APLA or APS? It's an antibody-mediated thrombophilia syndrome. What do I mean by that? It's a condition where there is increased propensity to form clots in the body. There are so many other conditions where there is increased propensity to form clots, like protein C, protein S deficiency, antithrombin 3 deficiency. These are all factor 5 Leiden mutation. These are all thrombophilic states where, because of the impairment in the mechanisms preventing clot, we tend to develop clots easily. Just give an additional small risk factor and patient develops a. So APLA or APS is also one such condition where the increased propensity to develop clots is because of formation of certain antibodies in the body, which can happen in SLE or without SLE. And being associated with SLE, APLA or APS is more common in females than males. And in these patients, the clots in the venous system develop more commonly than arterial, but arterial clots also happen. Arterial clots can also happen. Generally, arterial clots are because of atheromatous plaque rupture. Venous clots are because of thrombophilic syndromes. So if I have protein C, protein S deficiency, antithrombin 3 deficiency, factor 5 Leiden mutation, or APS, I'm more likely to develop clots in the veins, like the cortical vein thrombosis, deep vein thrombosis or DVT, eventually leading to pulmonary embolism. But if I have atheroma burden, a high LDL, development of atherosclerosis, someday plaque ruptures, platelet plug forms, and then I have a clot in the arterial system, right? Arterial system clots are more to do with the atherosclerotic risk factors. Venous clots are more to do with the thrombophilic risk factors. Okay. So the most common complication that this increased propensity for the clot leads to is development of deep vein thrombosis. So DVT is the most common complication of having APS, antiphospholipid syndrome. The most common arterial complication is going to be development of stroke. So these APS patients, though most commonly they present with DVTs or sometimes negative obstetric outcome, but some of them can also develop middle cerebral artery or anterior cerebral artery strokes. Okay, and then obstetric complications, it can lead to intrauterine death because the blood vessels connecting the fetus and the mother can get thrombosed, depriving the fetus of nourishment, and the fetus can be there can be intrauterine fetal death. So intrauterine death and premature delivery. These are common obstetric complications of APS. Now the question is, how do I get to know that a person is likely to be having antiphospholipid syndrome? So please remember, any patient who presents with spontaneous venous thrombosis without a trigger. See, what do I mean by trigger? Let us say I took a flight from Bangalore to San Francisco or Newark Airport. Long flight, okay, economy class, crumpled. Okay, I'm not very tall, but let us say the patient who I'm talking about is like 6.5 feet tall. So he's sitting in a very cramped place, not able to move his legs. So there is prolonged stasis of blood in the lower limb veins, and that got clotted. Fair, there is a trigger present there. Or let us say I had a road traffic accident, I had some hip fracture, now I'm bedridden, I'm not able to move my limbs. So there was stasis of blood in my lower limb veins, they got clotted. Well, there was a trigger. But let us say I didn't go through any of this. Okay, so I went to office and then I started noticing some headache, and I went to a clinic. He gave me some medication, it did not come down. I became a little drowsy. My wife took me to some other clinic, and there they got a scan done, and then they identified that I've got cortical vein thrombosis or cerebral venous thrombosis. There was no trigger, there was no stasis, nothing else. Such cases where you have a venous clot without a known trigger, you should investigate for thrombophilic states. So you should do the antithrombin 3, protein C, protein S levels, factor 5 Leiden mutation test. You should do those thrombophilic evaluation, and as part of thrombophilic evaluation, you should also do evaluation for APS or APLA. Similarly, if there are recurrent pregnancy loss or intrauterine fetal deaths, in those females also, you should investigate for APLA. So until and unless you have a high index of suspicion and investigate, this diagnosis does not come to you directly. SLE comes to you. It's like, okay, there is a rash, arthralgia, fever, ANA positive. Okay, you know, this story is typically fitting into SLE. But APS, you need to have that high index of suspicion. So any unprovoked or untriggered venous thrombosis, consider antiphospholipid syndrome as one of your differential diagnosis. And once you're considering this as a differential diagnosis, do the necessary investigation to establish or rule out this diagnosis. So let us say I'm doing the investigation, but how am I going to interpret? So the interpretation for the diagnosis is, we are going to follow a criteria called as revised Sapporo criteria. And in this revised Sapporo criteria, we have clinical criteria and laboratory criteria. So we need at least one clinical criteria and one laboratory criteria. Okay, so what are the clinical criteria? We need at least one event of arterial or venous or small vessel thrombosis. Like, okay, there is a history of stroke, or there is history of cortical vein thrombosis, or there is history of DVT, or there is history of pulmonary embolism. Okay, so then one clinical criteria is already satisfied. Or instead of these thrombotic events, let us also take into account the obstetric history. So if there is death of one or more than one morphologically normal fetus after 10 weeks of gestation, means 11th or 12th week of gestation, there was a death of a morphologically normal fetus. Why are we stressing on morphologically normal fetus? If the fetus was morphologically abnormal, it could be having an intrauterine death and premature termination just because of those like the abnormalities in the fetus may not be compatible with the fetal survival. If there is no development of internal organs, the fetus anyway will not be surviving, and then it will be expelled out. But if as per their gestational age, the fetus has developed morphologically normally, but still there was either IUD or the premature termination, in that case, it is probably pointing towards decreased blood flow to that fetus. That's why it died and terminated. And that could be because of the thrombosis, and that thrombosis could be because of APS. So that's why if there is death of one or more than one morphologically normal fetus after 10 weeks of gestation, or if there is premature delivery of a morphologically normal fetus before 34 weeks of gestation, or more than or equal to 3 consecutive spontaneous abortions within 10 weeks of gestation. After 10 weeks, I need a morphologically normal fetus. Of course, before 10 weeks, morphology cannot be commented about. But then if it is before 10 weeks, I'm not taking just one termination as or death as sufficient. I need 3 consecutive spontaneous abortion, like first pregnancy, second pregnancy, third pregnancy, all of them there was spontaneous abortion before 10 weeks of gestation. Then this criteria will be satisfied. So obstetric part, please by heart, because teachers are technically looking at it, whether you have mentioned the wordings correctly or not. This part is anyway easy to mention. One venous or arterial thrombotic event or negative obstetric history. Any one of them present, clinical criteria satisfied. Now I need one laboratory criteria. The laboratory criteria is presence of antibodies. So what are the antibodies we are expecting here? There are 3 major antibodies. The first one is anti-cardiolipin antibody, usually abbreviated as ACL, anti-cardiolipin antibody. Second one is anti-beta-2 glycoprotein antibodies. And the third one is lupus anticoagulant, usually abbreviated as LA. So these are the 3 antibodies. Out of these, at least one antibody should be positive. Means I should have one arterial or venous thrombosis or the obstetric criteria plus at least one antibody positive. Okay. Then you can consider it as Sapporo criteria positive for APS. Point to note here is that this Sapporo criteria, if it comes positive once, means the antibodies come positive once, that is not enough. I need to have this antibodies persistently positive. Now, how would I say that this is persistently positive? If I have done 2 samples, done 12 weeks apart, means 3 months apart, and both are positive, then you can say, sir, antibodies are really positive and this patient had negative obstetric history. So now I am thinking that this is a case of APS. Means like, okay, today I saw a patient, she gives me a history of recurrent spontaneous abortions and obstetrician is evaluating for that case and he has referred to me to see if it fits the APS. So obstetric history wise, it is ticking the box. Now I look at the antibodies. Let us say lupus anticoagulant turned positive. Now, immediately I'm not going to jump to say that this is a case of APS. At this point of time, I will tell the obstetrician that, sir, it is highly likely APS. I will be doing a repeat lupus anticoagulant and the other antibody test after 3 months. If that also comes positive, then I can say it is confirmed APS. And once the patient comes back after 3 months and the lupus anticoagulant is still positive, that means it is a case of APS. The diagnosis is established. Now, once we have established the diagnosis, how are we going to manage it? Okay. Now, in those patients of APS who are asymptomatic, which if you're following the Sapporo criteria, it is unlikely because Sapporo criteria says a clinical plus lab criteria should be there to call it as APS. But in a SLE patient, if lupus anticoagulant is positive or anticardiolipin is positive, we are considering it as query possible APS. Those patients at this point of time may not have a venous thrombosis, they may not have a arterial thrombosis or may not have a bad obstetric history. But having these antibodies, we know that they are prone. So in those patients, we should at least start aspirin. In your OBG, you might have seen a lot of females coming for routine follow-up and they are on aspirin because they are prone for APS. Okay. But if there is even a single event of thrombosis, if the patient had a DVT, cortical vein thrombosis or a stroke, right, any of these, in that case, aspirin alone is not sufficient. You need to treat them with aspirin plus. Aspirin alone is not sufficient. We need to start with an anticoagulant. This anticoagulant, preferably warfarin. Warfarin can be considered as the first choice because of its efficacy evidence, or alternatively, you can use direct acting oral anticoagulants like apixaban, argatroban, right? These can be used as the second choice oral anticoagulants. So if there is a single event of thrombosis, the patient will require aspirin and an anticoagulant lifelong, apart from treating the underlying SLE. And if no such events are documented, only antibody positivity and no clinical symptoms present, then at least give aspirin lifelong. Now the issue is pregnancy, because APLA is more common in reproductive age group, because SLE is more common in reproductive age group. So if I get some 18, 19, 20-year-old female, she has not yet completed her family, she still wants to get pregnant, she has SLE, anticardiolipin antibody is positive, or she already has a negative obstetric history, she has lost multiple fetuses in the past. Now they want this pregnancy, they want to plan for a pregnancy, or they are pregnant now and they want to somehow make this pregnancy sustain successfully till delivery. What can I do? APS can be a reason for premature delivery because of the fetal ischemia, reduced blood supply to the fetus. So I have to prevent the thrombosis in these individuals. But the problem is aspirin is not enough if there is already a bad obstetric history, and I can't give warfarin. Then the safety of many of these newer oral anticoagulants also is not well established in the pregnancy or first trimester. So then what should I do? So we treat them with aspirin, plus we can go ahead with heparin. And because throughout the pregnancy we are giving heparin, I can't be giving the unfractionated heparin, which requires multiple daily dosing and regular monitoring of APTT. It's mess. Instead, we are going to go ahead with low molecular weight heparin. Post pregnancy, slowly you can switch to oral anticoagulants. Okay, so this is about the antiphospholipid syndrome. Vidhi Patel, so if time permits, I will try to cover vasculitis today. But I've asked the team to give me 2 more slots, one for endocrine, where we will complete the adrenal disorders, and probably we will require 1 more session on rheumatology also, so that we can cover vasculitis, Sjogren's, and other small topics. So the fetus is totally dependent on maternal circulation for the nutrition, right? Of course, it is not eating food inside the mother's womb. It is getting the passive nutrition. But if there is thrombosis in the maternal circulation or the connecting vessels between the maternal and the fetal circulation, then the fetus will be deprived of blood supply and the fetus dies. So till that thrombosis happens, the fetus would have developed normally. It will not have any morphological abnormality, no deformities. But once the thrombosis develops, it's not getting blood supply, and because of the lack of the blood supply, the fetus dies, and that will result in abortion. Okay, so next chapter we are going to do is scleroderma. Now, what is this scleroderma? Like, let us understand some terms. Scleroderma is also used as an alternative for what we call as systemic sclerosis. Now try to decode the meaning of this word, because in medicine the name holds a lot of information. Okay, sclero means damage or fibrosis, and derma means skin. So in simple words, scleroderma refers to skin fibrosis. That's a basic understanding of this meaning. Okay, but then we come across this term called as morphia, which is also for skin fibrosis. Then when exactly I should call it as scleroderma? Remember, if there is only skin fibrosis, then we call it as morphia. But if there is skin thickening and along with that internal organ involvement, then we call it as systemic sclerosis, or an older term, scleroderma. Systemic sclerosis is a current terminology, just like how APS is a current terminology, not APLA. Systemic sclerosis is the current terminology, where you have skin thickening or skin fibrosis plus you also have organ involvement. So if there is no organ involvement, only skin is thickened, then it is morphia. But if the skin is thickened plus there is evidence of organ involvement, then we call it as systemic sclerosis. Now within the systemic sclerosis, we have 2 types. One of them is called as limited cutaneous. The other one is called as diffuse cutaneous. Diffuse cutaneous. Now, what do I mean by that? Of course, as the name says, it is talking about the extent of skin involvement. So if I have systemic sclerosis where skin is thickened or fibrosed, and there is also organ fibrosis or organ involvement, now I will look at how much skin is involved. If the skin involvement is restricted to distal parts, what do I mean by distal? The forearm and hands. Remember, in neuro also we call this hands and forearm muscles as distal, right? Arm and shoulder as proximal. So if the skin involvement is restricted to forearm and hand in the upper limb and the legs and feet in the lower limb, it is not extending proximal to that, then we will call it as limited cutaneous. So in this picture, as you see, the skin thickening is restricted distal to elbow joint, distal to knee joint, then we are going to call it as limited cutaneous. Limited cutaneous. And if the skin involvement extends proximal to the elbow and the knee joints, like as you see in this image, the skin thickness is extended proximal to the elbow joint, extended proximal to the knee joint, then we will call it as diffuse cutaneous. And in both the cases, you can have involvement of facial skin. Limited as well as diffuse, you can have involvement of facial skin. Now I have a simple question. Why are we doing this classification? Is it just to understand how badly the skin is involved, or there are other clinical consequences? Remember, there are other clinical consequences. What is it? Limited cutaneous and diffuse cutaneous, to be very frank, though they have a similar basic pathophysiology, they behave like two different diseases. It's like two siblings. They have same parents, same mother, father, but one can be criminal, the other can be police, right? Amitabh Bachchan and Shashi Kapoor. So you can get that kind of a picture. So these two behave totally different as diseases. So if I get a scleroderma or systemic sclerosis patient, and if I see skin involvement is only restricted to the distal parts, then it'll have its own different course of disease progression. And if it is also extending to proximal parts, this patient will have his own different course of disease progression. What are the differences? We will discuss, and that is what your teachers are going to expect you to write in answer sheet. They are objectively looking for whether you can elaborately list the differences between limited cutaneous and diffuse cutaneous. Okay. Now, what is the main cytokine involved in the pathogenesis of scleroderma? When we spoke about SLE, we learned that it is interferon 1, against which we made anifrolumab. In case of rheumatoid arthritis, it is TNF alpha. In case of scleroderma or systemic sclerosis, it is transforming growth factor beta. You know what it does? It activates fibroblasts. Transforming growth factor beta activates fibroblast, and those fibroblasts start depositing abnormally intense, high density collagen in the tissues, and that's why we are getting this fibrosis of the skin and organs. Apart from that, it might also activate VEGF, which will cause blood vessel proliferation. So you can have vasculitis as a component. So in scleroderma, you have to remember only two things. There is fibrosis and vasculitis. So most of the manifestations are related to either fibrosis or vasculitis. So what all clinical manifestations we can get? We can get calcium deposition in the skin and soft tissues. We call it as calcinosis cutis. Like you see in this picture, all these white spicules that you're seeing is a calcium deposition in the skin, and that is also visible on the X-ray. Okay. Second, you can develop thickening of the skin of your distal parts, hands and fingers. And because the skin becomes thickened, the fingers start going into fixed flexion deformity. It becomes difficult for them to extend. And this skin thickening is associated with fibrosis and inflammation. And that swelling of the skin and the soft tissues of the fingers make the fingers appear like the shape of a sausage. You know, the meat sausages. So you will get sausage shaped digits and fixed flexion deformity. Then there can be loss of pigmentation around the hair follicles, giving rise to salt and pepper skin. Salt and pepper skin. Okay. And as I've already told you, that if you're thinking about systemic sclerosis, you have to think of fibrosis plus vasculitis. Fibrosis plus vasculitis. So this deformity that we saw is because of fibrosis of the skin. But then there is also vasculitis, and vasculitis makes the blood flow to the organs reduced, and because of that you can get Raynaud's phenomenon and ischemic ulcers. So in the same patient with this fixed flexion deformity and sausage shaped fingers, you can also see, if you closely examine, there are ulcers. These ulcers are ischemic because the blood flow to this part was cut due to vasculitis. Okay. Then the vasculitis also leads to telangiectasia, right? Abnormal dilatation of arterioles and capillaries. Okay. Apart from that, the thickening or fibrosis of the facial skin makes it difficult for them to open the mouth completely. It leads to what we call as microstomia. So I will discuss both limited and diffuse cutaneous in detail in a bit. We will just go through the important images. It leads to microstomia or small opening of the mouth. Why is that happening? Because all the surrounding facial skin has become fibrosed or thickened. It's not able to open properly. Similarly, the thickening of the skin of the nose makes the nose appear like a parrot beak. So you can have parrot beak nose. Okay. And now the whole facial skin is fibrosed. It becomes difficult for them to give expressions, right? Like if I give expression, my facial skin moves, right? But then you might have seen some celebrities who have paralyzed their facial muscles by Botox and they can't give the expression. They look like they're wearing a mask. Okay. So similarly, these patients also struggle to give expressions on the face because even if the muscles move, the skin cannot move. It is hardened, fibrosed. So this face is also called as Moscow faces or mask-like faces. We use a similar term, the mask-like face, for Parkinson's disease also. So in Parkinson's disease, the contraction of facial muscles is slow. That's why they're not able to give expression. Here, muscles can contract, but overlying skin is not able to move. So that's why they're not able to give expressions, right? So these are all some common manifestations you should be able to write. So among all the clinical features that we get in scleroderma, the most common manifestation is going to be Raynaud's phenomenon. Raynaud's phenomenon. Now, what do I mean by Raynaud's phenomenon? Raynaud's phenomenon refers to patients experiencing pallor, numbness, and sometimes even pain on exposure to cold or water. Of course, cold water only. Why is this happening? Because as I've already told you, systemic sclerosis is equal to vasculitis plus organ fibrosis. So vasculitis of small blood vessels makes the blood vessel sensitive to the vasoconstriction on exposure to cold. Normally itself, when I'm exposing my extremities to cold, there will be vasoconstriction. Because when you expose yourself to cold atmospheric temperature, now from the body surface, I might start losing the heat to this cold environment. But body wants to keep the normal body temperature. So what body will do? It will prevent the blood coming to the peripheries or surface, because it is the internal organ heat through blood coming to the surface and we are losing that heat to the atmosphere. But if I cause vasoconstriction, this blood is not coming to the surface so that I can preserve the body temperature, right? And to help do this, we have the sympathetic nervous system. So whenever we get exposed to cold, the sympathetic nervous system gets activated. It causes the vasoconstriction. So it is a normal physiological response. In extreme cold of Delhi, when you go, you see your hands appear pale, right? You go to Kulu, Manali, your hands will become pale. It's normal physiological manifestation. But in these patients, there is a exaggerated response. Like these women who have systemic sclerosis, they just wash their utensils in the normal room temperature water. But even that cold exposure causes intense vasoconstriction. So they will notice pallor, and because the blood flow is now cut, they experience numbness or tingling sensation, sometimes even frank pain. And because they go through these repeated attacks of Raynaud's phenomenon, every time they go through this Raynaud's phenomenon, vasoconstriction happens, blood flow to the fingers is cut, and they can develop ischemia of the fingers, and they can develop these ischemic ulcers, right? Apart from that, ulcer healing itself leads to scarring of the skin. Apart from that, there is definitely fibrosis of the skin happening. So all put together, they develop this sausage-shaped fingers with the fixed flexion deformity, right? And then because of this repeated ischemia, the finger starts resorption. So finger starts shrinking in size. So eventually they will have severe deformity with shrunken fingers, difficulty to open mouth, they struggle to eat the food. So life becomes hell for these patients. And the bad news for a systemic sclerosis patient is the principal cytokine is TGF-beta. And we don't have effective drugs to block TGF-beta selectively at the affected organ level. So as of now, the treatment of systemic sclerosis is not great. SLE, we have advanced a lot, but in systemic sclerosis, unfortunately, we are not able to help patient much. Okay. Then apart from that, as we just studied, there is organ involvement, right? So what all it can lead to? In the lungs, it can lead to ILD. ILD is typically more common in diffuse cutaneous variant. Diffuse cutaneous systemic sclerosis. And they can also develop pulmonary arterial hypertension. That is more common in limited cutaneous variant. So that's why I said that diffuse cutaneous and limited cutaneous, though they have a same parent pathophysiology, fundamentally they are like two different siblings behaving totally different. So if I have limited cutaneous, I'm prone to develop pulmonary arterial hypertension. But if I have diffuse cutaneous, I'm prone to develop ILD. The chance of me developing pulmonary arterial hypertension is less. Okay. So in CVS, it can also lead to coronary artery disease because there is vasculitis. It can lead to coronary artery disease. And in kidney, it can lead to what is called as scleroderma renal crisis. It is multifactorial, but one of the principal pathophysiology is that in patients with scleroderma, there is vasculitis and organ fibrosis. So this vasculitis results in vasoconstriction and fibrosis of the blood vessels layers can also lead to significant shrinking of the blood vessels. So renal perfusion can get reduced, and when renal perfusion gets reduced, RAS can get activated. So when RAS gets activated, what will happen? We will have angiotensin II coming, causing further vasoconstriction and increase in the BP. So scleroderma renal crisis is nothing but a hypertensive emergency due to high renin. It is nothing but a hypertensive emergency. Due to high renin. So it's a high renin hypertension. Now tell me, if I get this patient of scleroderma renal crisis, once upon a time, scleroderma renal crisis was the most common cause for death in scleroderma patients. Not today, because now we know the underlying mechanism. The renal crisis is happening, that basically a hypertensive emergency, sudden shoot up in BP, it can lead to intracranial bleed, heart failure, various other consequences. And it's all because of high renin. And can I block it? Yes. So I can treat these patients with either AC inhibitors or ARBs. So drug of choice, if a patient presents with scleroderma renal crisis, or in simple words, any patient with scleroderma who already has skin thickening, microstomia and all, and now he comes with a high blood pressure. First drug you should be administering is an AC inhibitor or ARB, because it hits the root cause. In addition to AC inhibitor or ARBs, for a quicker lowering of the BP depending on the severity of the situation or gravity of the situation, you can use additional drugs. But AC inhibitors or ARBs you have to give to hit the root pathophysiology. Okay. What else it can lead to? It can also affect the GIT. So in GIT, what it causes? It causes something called as GAVE. What GAVE stands for? Gastric antral vascular ectasia. So you get small abnormalities of small blood vessels in the gastric, in the stomach. Ectasias, small vascular deformities or malformations, and these result in upper GI bleed. They can present with upper GI bleed. Second thing they can develop is esophageal dysmotility. Esophageal dysmotility. Both of these are more common in limited cutaneous variant, limited cutaneous systemic sclerosis. I forgot to mention, the scleroderma renal crisis is more common in diffuse cutaneous systemic sclerosis. Now, I gave you a lot of information, right? This is more common in limited cutaneous, this is more common in diffuse cutaneous. How do I remember all of this? It's easy to just remember the list. Like it's easy to remember, in lungs I will have ILD, pulmonary arterial hypertension. CVS I will have coronary artery disease. In kidney I will have renal crisis. In GIT I will have antral vascular ectasias or esophageal dysmotility. So to make it easy for you to remember, I'll just tell you a simple approach. What is it? You have to just think about. Don't write it in a paper. It is just for remembering. If you're thinking about limited cutaneous, think about blood vessel or vasculitis. And if you're thinking about diffuse cutaneous, think about organ fibrosis. See, because the inflammatory mediators Inflammatory mediators will tend to cause a vasodilatation, and to counter that, the vasoconstrictory mediators will be increased and they will cause the vasoconstriction. So just think about limited cutaneous, think about vasculitis, and diffuse cutaneous, think about organ fibrosis. Now things will become clear. So pulmonary arterial hypertension. Am I thinking about blood vessel or organ fibrosis? Pulmonary arterial hypertension, artery. I'm thinking about blood vessel. So where it will be more common? Limited cutaneous. Okay. Then gastric antral vascular ectasia, vascular. Where it will be more common? Limited cutaneous. Right. On the other hand, ILD, lung fibrosis. Where it is more common? Diffuse cutaneous. Scleroderma, renal crisis, kidney involvement, organ, again, where it is more common? Diffuse cutaneous, right? So if blood vessel comes to your mind, think about limited cutaneous. If an organ comes to your mind, think about diffuse cutaneous. But make sure you don't write it in your answer sheet. It is just for you to remember. Okay. So now we understand that these two subtypes of scleroderma, they behave entirely differently. So if I have diffuse cutaneous, I will tend to develop ILD and I'm prone to develop renal crisis. So you need to always keep monitoring my BP, and patient should report to the hospital immediately if they see a surge in BP, because they may be heading into renal crisis. On the other hand, if I have the limited cutaneous, then I'm prone to develop pulmonary arterial hypertension. So as a doctor, you should be constantly monitoring, regularly checking my pulmonary artery systolic pressure through echo. And if there is any evidence of this rising, then you have to do more detailed investigation to establish the diagnosis, that is through right heart catheterization. Mean pulmonary artery pressure more than or equal to 20 millimeters of mercury confirms that I have pulmonary arterial hypertension, and accordingly you have to start the treatment with either calcium channel blockers or phosphodiesterase 5 inhibitors. Then I may be also prone to develop GABE, so you need to regularly screen with a endoscopy, and if you encounter the gastric antral vascular ectasias, you have to treat accordingly. So once you know which variant it is, it becomes easy for me to further monitor the case and treat accordingly. But then how will I get to know? Yes, one is extent of skin involvement. If I get a patient with scleroderma where I see skin being thickened even in the arms, then I know it is diffuse cutaneous. If arms are not involved or the thighs are not involved, the involvement is restricted to distal parts, distal to elbow and knee joint, then it is limited cutaneous. But can lab investigations help me to predict? Yes. Antibodies. So in patients with the limited cutaneous, we typically get anti-centromere antibodies. Anti-centromere antibodies. Yes, limited proximal, diffuse distal with respect to skin involvement. Limited more of blood vessel disease, diffuse is more about organ fibrosis disease. And in diffuse cutaneous, we get anti-DNA topoisomerase antibody, or which is also called as anti-SCL70 antibody. And you can also get one more called as anti-RNA polymerase antibody. Most important antibody for the limited cutaneous is going to be, that is the only one, anti-centromere, and for the diffuse cutaneous it is going to be anti-DNA topoisomerase or anti-SCL70. SCL70 is easy to remember. SCL refers to scleroderma. So anti-scleroderma 70 antibody. So if I diagnose a case as having scleroderma and I get these antibodies done, then I know which particular complications this patient is prone for. So if the patient has anti-centromere antibodies, he is prone for blood vessel involvement, pulmonary arterial hypertension, right? Then Raynaud's phenomenon, gastric antral vascular ectasia, upper GI bleed, those complications. But if I have anti-DNA topoisomerase, then this patient is prone for renal crisis and ILD. So accordingly, I can monitor and follow. Right. Now the question is, how would I remember? I made it easy to remember the manifestations. Limited cutaneous, think about vasculitic manifestations. Diffuse cutaneous, think about the organ involvement or organ fibrosis. How do I remember antibodies now? So remember, if I look at a cell, like let us say this is a cell I'm looking at, and I give you a task. I want you to find out where all you get the centromere in the cell and where all you get the DNA in the cell. So where will I get the centromere? Centromere is central part of the chromosome. right? Do I find it throughout the cell? Like this is nucleus and this is cytoplasm, right? Will I find the centromere in the cytoplasm? No. Centromeres will only be found in the nuclei because the chromosomes will be in the nuclei. That too, will I find the centromeres throughout all the stages of cell cycle? No, only in selected stages where the cell is replicating and the DNA material is aligning in the form of chromosomes, you will be able to see. Otherwise, when the cell is not replicating, the chromosomes are not aligned. The DNA inside the nucleus is diffusely distributed as lace work or a thread work, what you call as chromatin. So the centromere is present only inside the nucleus, that too during some phases of cell cycle and not always. So can I say that centromeres have a limited presence? Yes, they are present only in nucleus, that too only in selected part of the cell cycle. So they have limited presence. Centromeres have limited presence. That way you can remember it as limited cutaneous scleroderma, right? On the other hand, if I talk about DNA, DNA is always there in the cell, need not be aligned as centromere, but it's always there in all phases of cell cycle. And is DNA restricted to the nucleus? No. DNA can be found inside the cytoplasm also. Where inside the cytoplasm? You have mitochondria, right? And inside the mitochondria, you have DNA, the circular DNA. So DNA has more diffuse presence inside the cell, nucleus as well as cytoplasm. So that way you can remember anti-DNA topoisomerase is for diffuse cutaneous. Or in more simple words, you can remember it as D for D. Diffuse cutaneous, you have DNA topoisomerase. Limited cutaneous, you have anti-centromere with very limited presence of centromeres. So that makes it easy for you to remember and you can replicate it in the answer sheet. Okay, so I just put a small table comparing the differences between limited cutaneous and diffuse cutaneous. So as we just learned, the limited cutaneous, the involvement of the skin is restricted to distal, means elbow joint onwards, forearm and hands. In case of diffuse cutaneous, it extends proximal to knee joint in the lower limb and proximal to elbow joint in the lower limb. Now coming to the Raynaud's phenomenon. Raynaud's phenomenon is more frequently encountered in patients with limited cutaneous. It is less frequently encountered in patients with diffuse cutaneous. I have already told you, you just remember this fact. Limited cutaneous, think about blood vessels. Diffuse cutaneous, think about organ involvement, organ fibrosis. So blood vessel involvement is less common. So less frequent Raynaud's phenomenon, not as bothersome as you get in patients with limited cutaneous. Okay. And because there is more profound vasculitis and more profound vasoconstriction, these patients are also prone to develop increased risk of developing digital ulcers. Now, when I say digital ulcer, I'm not saying ulcers in the digital media. Finger. So ulcers of the fingertips are very common. We have already seen an image where there was an ulcer of the fingertip. That's because of this Raynaud's phenomenon and vasoconstriction. So they're more likely to occur in limited cutaneous than diffuse cutaneous. Okay. Then if there is joint involvement, it will be minimal in limited cutaneous. Think about limited means mainly blood vessel, not organ. But organ involvement is more common in diffuse cutaneous. So arthritis is more common in diffuse cutaneous, right? Again, ILD is more common in diffuse cutaneous because ILD is lung fibrosis. Fibrosis means we're thinking about diffuse cutaneous. It is less likely to be encountered in a patient with limited cutaneous. On the other hand, pulmonary arterial hypertension is very common in limited cutaneous because we're talking about blood vessel, right? It is rare. It can occur, but it is not pulmonary arterial hypertension. It is pulmonary hypertension due to ILD. These patients are prone to ILD. That can lead to pulmonary hypertension, but that we won't call it as pulmonary arterial hypertension. Pulmonary arterial hypertension is pulmonary hypertension in the absence of lung and heart diseases. Here, lung disease has resulted in pulmonary hypertension, then it is not called as pulmonary arterial hypertension. Okay. Renal crisis, we have already studied that renal crisis is more common in patients with diffuse cutaneous. It is rare in limited cutaneous. Okay. Then calcification of the skin, we saw an image, calcinosis cutis, which is more common in limited cutaneous and less common in diffuse cutaneous. In fact, many patients of limited cutaneous present with something called as CREST syndrome. This is something that your teachers often discuss in bedside. CREST syndrome. So what this CREST syndrome stands for? calcinosis cutis, Raynaud's phenomenon, esophageal dysmotility. Sclerodactyly refers to those fixed flexion deformity with the sausage-shaped finger. It's also called as sclerodactyly. Dactyly means, sclero means fibrosis, dactyly means finger. So scleroderma means skin fibrosis. But when that happens to the fingers, we call it as sclerodactyly. And then vascular abnormalities we saw in image on the face and other regions of the body, we will call them as telangiectasia. So calcinosis cutis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia together forms CREST syndrome. It is nothing but limited cutaneous with all these manifestations. So you can say that CREST is nothing but a subtype of limited cutaneous. Okay, so now we have understood all the clinical manifestations. Now the question is, how am I going to manage these patients? So unfortunately for a scleroderma case, diagnosis is always clinical because I can't estimate the TGF beta levels and I don't need also. So if I get this typical picture of Raynaud's phenomenon and skin thickening extending at least to involve the hands, you can conclude it as the scleroderma. Now depending on antibody profile or the extent of skin involvement, you will classify it as limited cutaneous or diffuse cutaneous. And once we have established, for the management, it's very challenging. Most of these patients don't get satisfactorily treated because we haven't hit any gold mine when it comes to the drugs manipulating the pathophysiology. SLE, rheumatoid arthritis, for all of that we have drugs literally manipulating the pathophysiology, and in near future we are going to get more precise. But scleroderma, we are still at the grassroots level. So right now the management primarily focuses on the symptomatic management. Tendon friction rub means because they have the arthritis, there is also involvement of tendons. They have tendonitis, and the tendonitis, the tendons are inflamed, and whenever muscle contract, tendons move, right? And because they're moving, they're going to rub with the joint capsule or the bone surfaces, and that rubbing creates a rubbing noise. When patients move their joints, they feel a rubbing noise, just like how some tight doors when we move make a noise. So that noise is what we call as tendon friction rubs. It is indicating that patient has developed arthritis and tendinitis. See, the vasculitis generally is because of inflammatory mediators. So when these inflammatory mediators tend to cause vasodilatation. But then body will always try to counter that vasodilatation by vasoconstrictory mediators, including the increased sympathetic tone. So they cause the vasoconstriction. Okay. So now coming to the management. Management is going to focus on symptomatic management. Like what can be the symptomatic management? Raynaud's phenomenon is the most common manifestation. So patients are often worried about doing even household chores, because even washing hands, taking bath, washing utensils, all of that is triggering Raynaud's phenomenon and creating an uncomfort for them. So how can I help them? Raynaud's phenomenon is due to vasoconstriction. So how can I help these people? I can help these people by causing vasodilatation. And what drugs can be used? We can, yes, consider beta blockers, but more effective than that, we have calcium channel blockers, well tolerated without affecting the heart rate. If I give beta blockers, yes, they will cause vasodilatation, but they will decrease the heart rate, they will decrease the cardiac output. So that is an unnecessary mess. So the drug of choice for Raynaud's phenomenon is going to be calcium channel blockers. And you know that there are two types of calcium channel blockers. What are those? Dihydropyridine and non-dihydropyridine. Can you give me an example for a dihydropyridine calcium channel blocker and an example for a non-dihydropyridine calcium channel blocker? Yes, all the dihydropyridine calcium channel blockers end with D-pin. Dihydropyridine end with D-pin. Amlodipine, nifedipine, nicardipine, all D-pins are dihydropyridine calcium channel blockers. And non-DHP calcium channel blockers don't end with dipin, like verapamil, diltiazem. They are non-DHP. Which one should I use if I have a patient with Raynaud's phenomenon due to systemic sclerosis? So please remember, the dihydropyridine calcium channel blockers have a minimal influence on the cardiac conducting system. They have only major influence on the blood vessels. So they will cause vasodilatation, decrease your BP, and they can treat your Raynaud's phenomenon. but they will not alter the conducting system of the heart. On the other hand, this non-DHP like verapamil or diltiazem, these have, in addition to causing vasodilatation, these have a action on AV node and SA node. They can block AV nodal and SA nodal activity. And in a normal person who have no abnormality of cardiac conduction, I do not want to unnecessarily block the AV node. If I have some arrhythmias, supraventricular arrhythmias, like PSVT, in those cases, yes, I might consider these drugs. That's why in pharmacology, you study these non-DHP calcium channel blockers under the antiarrhythmic drugs as well. So in this case, no issue with rhythm, right? It's only about blood vessel. So I should restrict myself to giving the dihydropyridine calcium channel blockers like amlodipine. It's very cost effective, highly effective. So it's the best drug to prescribe for these patients. Spend 50 paisa to ₹1 a day and your Raynaud's phenomenon is taken care of, right? There are new fancy drugs like S-amlodipine, cilnidipine and all. You may consider them, but they bring a lot of cost. Like they may cost 15-20 rupees a day. Instead, amlodipine is a beautiful drug. Only problem with amlodipine is some of them develop the pedal edema. So in that case, you might have to switch. The newer, especially S-amlodipine or cilnidipine, cause less pedal edema. So you may switch, but those who tolerate it well, just stick to amlodipine. For the renal crisis, it is because of the high renin. So we have already discussed. We are going to use AC inhibitors or ARBs as the mainstay of treatment. In addition, if I need to bring down the BP more urgently, I might consider the other vasodilators like nitroprusside or even beta blockers can be considered. And if patient has esophageal dysmotility, you can treat them with prokinetic agents like etopride, cisapride, metoclopramide. Those can be used. Primarily, we're trying to treat the symptoms. I forgot to mention. And if they have pulmonary arterial hypertension, we can treat them with dihydropyridine calcium channel blockers. And if they don't work, phosphodiesterase 5 inhibitors like sildenafil, tadalafil. Then we have endothelin 1 blockers like bosentan, ambrisentan. Then we have eloprost. So the list goes on. I think more we have discussed when we spoke about the pulmonary hypertension. So these drugs can be used if patient has got pulmonary arterial hypertension. Given a choice, if they are a good responder, then DHB calcium channel blockers will be considered as a first line treatment. But if they are not responding, we switch to other agents. Okay. So this is how we are going to manage a case of scleroderma. Okay. So now from the rheumatology, we still need to address rheumatoid arthritis. I'm leaving it to orthopedics faculty to cover that. But we will address the mixed connective tissue disorder, other overlaps in syndromes, Sjogren's syndrome, and vasculitis. Okay, so I'm leaving the notes on Sjogren's syndrome in this notes for you to go through. But once I get another session for rheumat, I will address the vasculitis, including small, medium, and large vessel. If they're asking a question, the question is going to be like this: classify vasculitis, and then they will either ask you to elaborate on small vessel vasculitis, or elaborate on medium vessel vasculitis, or elaborate on large vessel vasculitis. Sjogren's syndrome is most likely going to be a 5-mark question asking you to mention the clinical features, diagnosis, and management of Sjogren's syndrome. Mixed connective tissue disorder question is also going to be 3 or a 5-mark question depending on the university, asking you to write briefly about mixed connective tissue disorder. So I will try to align another session for covering these questions. And endo, as I've already told you, we will cover the thyroid and adrenal gland in one more session. So whenever I get that session, we will complete that. So for today, that's it from me. See, vasculitis simply means inflammation of the blood vessel. Scleroderma is one cause. There are hundreds of causes for inflammation of the blood vessel. Like temporal arteritis is a vasculitis. Polyarteritis nodosa is a vasculitis. In all those cases, different types of blood vessels get affected. In some conditions, small blood vessels get affected. In some conditions, medium-sized blood vessels get affected. In some vasculitic syndromes, larger blood vessels get affected. So vasculitis is equal to inflammation of blood vessels. Scleroderma is just one of the causes that we discussed for that. But vasculitis itself is a separate chapter where we will classify the causes for vasculitis into small, medium, and large vessel vasculitis. And within those subheadings, we will have different types. So that classification itself is a 5-mark flowchart. And then individual types is an additional 5-mark question. So they may ask you to classify and then write a brief note on individual. So 5 marks goes to classification and listing the examples, and then a note on one of the types of vasculitis, another 5 marks. So that I will try to address in the next class. So that's it from me today. I'll see you in the next class. Till then, have a good time. Bye-bye.